Good evening, everybody. I'm Etienne Richard, the CEO of Sonoscanner. We are very glad to be with you this evening during this very special event that we prepared for you. I'm very honored to introduce this webinar that will be animated by one of the finest world specialists, Professor Pr Bouchez from Ghent in Belgium. Thank you very much, Professor, for sharing your knowledge, your findings, your passion in ultrasound with us this evening. We plan to spend together about 1 hour. How it will be articulated. First, I will tell you some key points about Sonoscanner and the reasons of success today. Then we will listen to Professor Bouchez presentation with very exciting information during this presentation. I'm sure you're gonna all love it, and there are also some very important information for for COVID patients that we will discover this evening. Very interesting information for you to know. You are more than 600 physicians registered for this webinar this evening, coming from 49 countries. So most of you already are using our ultra-portable Ulight in your daily practice. Some of you not yet. Anyway, we'd like to thank you very much for taking the time to be with us tonight. It means a lot. Sonoscanner is now the leader in ultra-portable devices. All our products are designed and manufactured in France, near Paris, and you are free to visit your facility anytime you want. Since the beginning of the COVID crisis here in Europe, all our team has been focused on assisting physicians to cope with this disaster. So we put in place a very intense program to help you fight the COVID. This program is articulated in 3 phases. Acquisition of the ultrasound scanner with financial solutions that we can propose for you wherever you are. Installation of the ultrasound scanner reduced to the simplest way possible so you can be quickly able to assist the patients. And the third thing is the online training solution that we've developed, both offline and online, so you can have a full knowledge of your device instantly. As you already probably know, our ultra-portable system, Ulight and T-Light, has been recognized as the best ultrasound solution to deal with the COVID patients. And there is 6 main reasons for this. Of course, the image quality, we talked about it, so I will be brief on it. We've developed, together with Daniel Lichtenstein, on his recommendation, a microconvex probe for the lung ultrasound, and we are still working on this. It's a great probe for this investigation, and I'm sure Professor Bouchez will tell more about it. This solution is allow you to do some bedside imaging, which is very important on triage or during reanimation in post-operation survey. The 4th point is it's a dedicated professional device. What we mean is that's a device that stays in the hospital or in the clinical facility. There are accessories in the market using smartphone device. We do believe that you're a professional and you deserve a professional tool, and you surely don't want to bring your contaminated COVID smartphone and your probe back home with your family. So it's better to have your device safe in your professional environment. It's a very easy and easy to clean device, as it has no knob. So just a glass to wipe and some probes to clean after the use on the COVID patients. And finally, the 6th reasons that we discovered with your feedback is because those devices has the pulse wave and the tissue Doppler imaging, you are able to do some cardiac assessments of your patients. So I don't want to talk much more. I know you're all urging to hear what Professor Bouchez has to say. I'll get back to you at the end of this webinar. So thank you very much. Enjoy and take the Ulight with you.
Right. Thank you. So
We've got
welcome,
6 and
friends.
2 as answers so far. Thank you very
Welcome,
much, Professor.
colleagues all over the world. Welcome to this webinar on lung ultrasound in the COVID era. Coronavirus is a virus that didn't bring us a lot of joy, happiness, even sunshine in our lives. But as the virus slowly resolves, at least in Belgium, hope returns and we can see some sunshine, the sun rays between the clouds. Now, I've chosen this particular beautiful image because it's not only a beautiful image, but it resembles particularly something in lung ultrasound. With a little bit of imagination, you will be able to see this. I hope you can see my cursor. You can see this hyperechoic line resembling the pleural line for those who are familiar with some of the lung ultrasound. This broad, irregular pleural line in between the clouds, together with these comet tails, these, let's call in ultrasound language, these B-lines reaching down for the Earth. And this is, in fact, very specific sign, some imagination, for lung ultrasound, a lung ultrasound pattern in the COVID patients. Now, this will become clear at the end of this presentation. First of all, I will discuss during this webinar why and how we should perform lung ultrasound in the critically ill patient. Secondly, I'll briefly discuss the major signs of lung ultrasound, not all of them, because we're limited in time. And then at the end, I will show you some specific COVID patterns on lung ultrasound. And I'd like to start with this quote by Gandhi. First, they ignore you, then they laugh at you, and then they will fight you, and then you win. And this is, in fact, the true story of lung ultrasound. Lung ultrasound was considered to be impossible until a decade ago. This dogma of lung ultrasound is now recognized as wrong. And it's good to see the growing success of lung ultrasound now in this COVID period. Lung ultrasound can serve as a tool to diagnose lung pathology, but can also be used as a complementary to cardiac ultrasound in order to differentiate between the lungs and cardiac pathology. Now, the godfather, also my teacher, was or is Professor Lichtenstein from Paris, who has more than 30 years of experience in lung ultrasound and numerous publications. So I can really recommend, if you want to learn something about lung ultrasound, read the Bible of lung ultrasound, read this book of lung ultrasound in the critically ill patient. It's really recommended. Now, before we apply a lung ultrasound into clinical practice, it's crucial to define clinical science. Clinical science in a universal language, in a universal alphabet of lung ultrasound. So we can, as doctors, physicians, we can use lung ultrasound and use these tools appropriately to communicate with our colleagues or to write things down in a correct way. That's important. I'll give you an example. If someone says this patient has an A profile, then we should all know that he has no pneumothorax, we can give fluids, there is no pulmonary edema. Just by saying this patient has an A profile. So it's important to know this language. Is lung ultrasound accurate? As accurate as the good old chest X-ray? Yeah, even better. If we consider, and this was published by Professor Lichtenstein in 2014, if you consider pleural effusion, consolidation, pulmonary edema, and lots of other pathology, it is shown that lung ultrasound is more sensitive, more specific, and it has a higher accuracy in diagnosis. Now, we performed here at the university, of course, in a limited number of patients, a bit more than 40 patients. We checked whether this could apply also for COVID patients, and we came up with pretty good numbers with a high sensitivity, good specificity, and also diagnostic accuracy. We'll see within a few weeks if this number remains still that high, but we're progressing and including lots of more patients in the intensive care unit, but also at the emergency department. Now, which device do we need to perform lung ultrasound? Well, you can choose. There are a lot of devices available on the market. Also the probes, if you know what you need to see, you can use any probe you want. Of course, there are some limitations on these probes. I will explain in a minute. Now, as ultrasound has become essential in the evaluation of the lungs and the heart in the intensive care unit, you may consider big machines a problem. These are really problematic when you see these patients lying in the intensive care unit with a lot of machines, with the ventilators, syringe pumps, computers, etc. It's not easy to move around with big, large machines. As I show here in this small movie, it's pretty hard to move this between the bed of the patient and the other machines. So it's more convenient to use a smaller device. Like, for example, here below I use the ULAT, which is easy to transport. Also important, you don't need to plug it in. It has a battery, and it's starting up pretty fast within 12 seconds, which is really useful for bedside lung or cardiac examinations. Also, if you consider these high-risk infectious patients, you don't want to bend over the patient, especially not in a non-intubated patient. And then it's really convenient to take the machine, transport it to the other side, and continue your exam. Also, disinfection, as already mentioned, is quite a problem in COVID patients. And as we don't have keyboards, as in these big machines, just a touch screen and only one button, the on-off button, it's really simple and easy to clean the screen or the device itself and the probe using the dedicated wipes for cleaning. Now you have to consider when you choose a transducer that you all know that transducers can be of low frequency, meaning that your image is not so good, the resolution is not so good, but you can have a large penetration in the tissues. Versus high frequency probes, you get a much better image, but only a few centimeters of penetration depth. So this is a problem. Especially when you consider pleural fluid, you might use a low frequency probe when you want to scan and have a good idea or good image of the anterior fields. You might use a high frequency probe. Now, I like to use this one. It's the convex probe of the U light with a frequency between 4 and 10 megahertz. And with this probe, you can scan almost everything. You can scan vessels, you can scan the lung, you can scan the liver, etc. It's a universal probe, let's say. Maybe the most important thing when you use an ultrasound machine to perform lung ultrasound is that you have a dedicated default setting for lung ultrasound. You need to turn off all filters, because the most important principle in lung ultrasound is you want to see artifacts. Artifacts arising from the pleural line. And if you use these filters, harmonics, etc., it will blur. It's designed to get rid of all these artifacts. And so it blurs the artifact. So you need to turn off these filters. And then when turning off these filters, you can see much better these clear artifacts. So this is maybe the most important thing to remember: turn off the filters. Now, how do you start with your lung exam in a patient? Now, I like the method published by Lichtenstein and used by Lichtenstein. He uses the two-hand technique, where he scans two anterior points, 2 points at the anterior side of the chest, and 1 posterior point. Now, this way you can also, and that's important, to standardize your patient, especially when you want to follow up your patient in the next few days or weeks. You need to have a standardized method for this examination. You want to scan the same region over and over again and look for improvement. That's important. Now, how do you do this? In fact, you should use the hands of the patient, but that is not very practical, especially in these patients who are on the ventilator. So you use your hands, and you put your hand, first hand, next to the clavicle, and your fingertips in the middle of the sternum. And that is your first upper point, or the upper anterior blue point is just at the root between your ring finger and your middle finger. You place your second hand next to the upper hand, let's say, and then the second point, the lower anterior point, is in the middle of the palm of your hand. Yes? The lower side of your lower hand resembles the position of the diaphragm, which is also interesting. Now, this way you can actually standardize your two anterior points at each side of the chest. And then there is this posterior point, also called the Plebs point, posterolateral alveolar and pleural syndrome point. It's at the same level of your lower blue point, but as posterior as you can get at the back of the patient. Right? So you have 3 points which you need to scan on each side of the patient. Here I'm showing you how to do this in a practical way. It's very easy, and then you can scan each time, each day, the same method, the same points, and so you can look for improvement the patient. Right? Now, to be so complete as possible, I've added 2 axillary lateral points because I want to make a score of these pathological lungs. And therefore, I added on each side 2 points, 1 axillary point just below the preaxillary line in the axilla, and then at the level, also just below the preaxillary line, at the level of the lower blue point. Yes, these are 2 additional points, 2 additional regions I like to scan just to get a good idea of all the pathologic regions of the patient, and I can score these regions. And so each day I follow the score, which is shown here. This is in fact these 5 points on each side, which I cover. And these are in fact two patients. The first one is an older patient, where you see that the scores are a little bit lower than the patient on the right, which had much higher scores, but it's a younger patient. Yeah? Now you can see, if you use a score, that you can see an evolution, and even here an improvement, so here. So using these different regions, standardized areas of examination, and you can score them, you can follow up the patients and see whether they improve or not in the critical care unit. Now, I will not go over the alphabet completely, because there are a lot of signs, a lot of things in lung ultrasound. I will just cover the most important ones. And the basic sign is to look for the pleural line. The pleural line, and that's why, that's one consideration you have to make. You need to see, while scanning, 2 ribs, because the pleural line is lying between the 2 ribs, below the 2 ribs. And then you can see this hyperechoic, meaning a bright line that's moving around. This white line here, below the 2 ribs, is the pleural line. And this is moving, and this movement is called lung sliding. Yes, this is a normal lung during breathing, during ventilation. You should see this pattern. First step, look at the 2 ribs, look for the pleural line. Now, below this pleural line, you can see lung tissue. And within this lung tissue, there are other signs, other artifacts or signs which you can use in your assessment. In the literature, you will often find the bed sign. And the bed sign is the sign produced by the 2 ribs and the belly of the bed, which resembles a bed. So if you talk or you read about the bed sign, this means you see 2 ribs in the pleural line. That's all, right? Now, below this pleural line, you can see reflections of this pleural line at the same distance between the probe skin interface and the pleural line. So this distance from probe to the pleural line is the same as this and this. These are just mirror images, reflections of this pleural line. And if your pleural line is, when your pleural line is moving, when there is lung sliding, together with these reflections, horizontal lines, A lines, this means you have a perfectly normal functioning lung. Yeah? This is also called the A profile. These reflections are called A lines, indicate the presence of air. Now, some will ask me, will you see A lines in the presence of a pneumothorax? Yes, you will see A lines in the presence of a pneumothorax, but you won't see lung sliding. That's the difference. Besides horizontal reflections, you can have vertical artifacts. Artifacts arising from the pleural line, as shown here, these vertical artifacts. Now, these artifacts are due to the fact that when a lung becomes congested, filled with water, the first thing that will happen is your interlobular septa are getting filled with water, are getting bigger, and your ultrasound beam is being reflected in between these septa. And this creates all this tiny little reflection, create this vertical line. And this is the sign of interstitial edema, pulmonary edema, or cardiac edema. Yeah. So these B lines are in fact these sun rays, and like I told you in the beginning, comet tail artifacts. They also arise from the pleural line. They move with long sliding. They are laser-like, well-defined, and if they encounter an A line, they will erase it. It's the dominant version of the artifacts, let's say. Now, a B line indicates fluid. Now, you can see 1 or 2 B lines in normal lungs at the level of the fissura. In patients on the intensive care with normal lungs but are being ventilated for a couple of days, then in the dependent area, there will be a lot of fluid, and you can see there at the posterior side, you can see there B lines. Yes. But you shouldn't see more than 2 B lines. More than 2 is 3, 4, 5 B lines between 2 ribs. Again, that's the second point why you need to see 2 ribs always. More than 2 B lines between 2 ribs on the anterior side, pulmonary edema, cardiac pulmonary edema. Remember that. Here you can see 1 B line. Here you can see 3 B lines. So the B here is pathologic. The first one can be considered as normal. Okay. This is a question, quiz. How many B lines, think for yourself, would you count here? Remember that B lines are comet tail artifacts and not fading. Yes. Now, some of you would say, oh, I was 2. Some would say 3. Some would say, oh yeah, but this may be also B line. So 4, 5, 6 and 2, all right. Well, again, first look at the ribs. I can't see any ribs. And also this here is not a pleural line. This is an artifact, an image taken in a patient with subcutaneous emphysema. And subcut air in the tissue will create pleural line, similar thing, with the creation of these pseudo B lines. They aren't, because this is not a pleural line. You don't see any ribs. This is subcutaneous emphysema. It had nothing to do with fluid in the lungs or pneumothorax. It's difficult because some would say you need to give this patient diuretics. First look at the ribs, 2 ribs, and if you see the pleural line, then count from there. That's an important thing. Now, this B profile, fluid in the lungs, has been studied by Professor Lichtenstein, and he came up with the number of 18, the wedge pressure of 18. Above 18, you will see the presence of B lines in many patients. While if the filling pressures are pretty low, it's consistent with the A profile. Meaning that if you see a patient with the A profile, meaning that it means that these lungs are dry. And you can start filling the patient if you need to, of course. If there is hypotension, if there is shock, you can consider this a very quick sign to decide whether you should give fluids or not. If you see this, don't give fluids, give diuretics. All right? Here an example, a patient comes in, the ER or intensive care unit, shortness of breath, dyspnea. Okay, let's take our ultrasound machine. Let's take a look at the anterior points, the upper blue point, the lower blue point. You see a lot of B-lines, and this is considered to be pulmonary edema. This is also called, when you see this pattern in the 4 points, B profile. So you can use it in patients together with cardiac ultrasound to check for the heart function. And you can see these cardiogenic B lines. You can see this in heart failure patients with a reduced ejection fraction, like here. Or you can see it also, and even more, in patients with a preserved ejection fraction, with high filling pressures. They can suddenly develop pulmonary edema. While in the other types of shock, hypovolemic shock, due to bleeding, trauma, etc., you will see this pattern. You can start giving fluids, of course. Also, in right ventricular dysfunction, pulmonary embolism, let's say, for example, you will see dry lungs, of course, which is considered normal. Now, this can be interesting also in patients in the intensive care unit when there is a weaning problem, because weaning from the ventilator is most often a cardiac problem, congestion, and it will occur suddenly. You will have dry lungs, A profile, and suddenly 10 minutes, 15 minutes after weaning the patient, in some patients you will see a problematic weaning. And you can use your lung ultrasound, put it on the anterior chest. If you see this, this means the patient is in pulmonary edema. This is a problem. Yeah? Very easy to use in patients with difficulties in weaning from the ventilator. Of course, in a lot of patients in the intensive care unit, we will have to deal with consolidations and pleural fluid, as you all know. Here on the left, you will see a big consolidation with these tiny white dots. It resembles cookies, these, coconut things on top of it. It looks like a cookie, but it's in fact these white dots are bronchograms, air bronchograms, yeah, within this consolidation, with a little bit of pleural fluid. Here, on the other hand, you have a lot of fluid. So this might be, this is also consolidation, might be progressive atelectasis due to the presence of a lot of pleural fluid. Interesting also, if you have a patient, COVID or other patients, you can check with the lung ultrasound whether to check whether there is still atelectasis or not. So in this, on the left, is the same patient, before and after the application of PEEP. And you could titrate also using this way your PEEP level. So it can, ultrasound may help you in the recruitment of the lungs. B-lines can, I've told you, in cardiogenic pulmonary edema, B-lines are all over the place, everywhere on the 4 anterior points. But sometimes you will find a mixed version, where you can see A profile or A lines in 3 quadrants, while in 1 quadrant there is some B-line pattern, which might indicate also presence of a localized pneumonia. Think of this. If you want to measure, there's a question I often get, if you want to measure pleural fluid, you can do it in several ways. The most easiest way is the patient is in 15 degrees supine position. Normally you should scan longitudinally you rotate your probe, and then you can have a CT-like image. You just measure from the thoracic cage to the lung line, presence of the lung here. You measure this and you get centimeters or millimeters. And then there are a lot of formulas that's been published a lot of times, and each publisher with another kind of formula. But remember that if you see pleural fluid and you have a very small amount of pleural fluid, don't puncture or try to puncture this, because there is a risk of pneumothorax whenever you have less than 1 centimeter. If you have more, you can consider puncturing pleural fluid. And to estimate the amount of pleural fluid, you could say that the most easiest way is just multiply the septal distance times 20, and this gives you more or less the amount of pleural fluid present in that patient. Again, lung ultrasound can be used together with the cardiac exam to define certain pathology. And I want to share with you, I've just mentioned pleural fluid. In right heart failure, you often will see pleural fluid. Cardiac failure will get or will give pleural fluid. Remember that in pulmonary emboli, sometimes you will get subpleural consolidation. Not very frequently, but it may occur. Yeah? A centimetric consolidation in pulmonary emboli. Of course, and this is also interesting in COVID patients, because they are very hypercoagulable, you should check the vessels, vascular venous system. And sometimes you will find thrombi in these vessels. Yeah. Yes. Here I'm checking the V point just above the knee. Check whether there is a thrombus present. You can also check the femoral vein. You can check here the veins in the lower leg. And you can try to compress them by pushing at the back of leg. See whether this vein is compressible or not. Yeah? And a vein that's not compressible is highly suspicious for venous thrombosis. Also, again, in hypovolemia, you will have dry lungs and A profile, but together with visualization of the IVC, you could check, or these are additional signs for the presence of hypovolemia. Now, Professor Lichtenstein has made, for patients who are dyspneic, pulmonary respiratory problems, he created this blue protocol. And using this protocol, you can differentiate quite some pathology, from pneumothorax to pneumonia to pulmonary embolism to cardiogenic edema. Very useful for patients with respiratory symptoms. Okay, now you know almost everything of lung ultrasound. Let's see what we can see or detect in COVID patients. Here, this is a normal lung. And I suppose you've never seen such a beautiful, or you will see such a beautiful ultrasound image of lungs, because these are my lungs. But what you notice is here, luckily it's quite normal. You see the pleural line with A lines, and here there is some lung sliding and with the presence of A lines. So luckily I'm not in pulmonary edema. Now, just to show you the difference between a normal lung and a COVID lung. If you see here, this pleural line is good visible, but it's not really enlarged, thickened. While this pleural line is good to be considered thickened. It's irregular. It's irregular, and it has some very small consolidations just below the pleural line. And together with these consolidations, you have to remember that consolidations is also fluid problem, localized fluid problem. So this will create these B-lines from this consolidation. In fact, they're not called B-lines, or sub-B-lines, but you see the consolidations here, 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 while there is a long sliding, a thickened, irregular pleural line with subpleural consolidations and the presence of these B-lines. Here another one, a thickened pleural line with here, if you can see closely, you can see a small consolidation. Here probably also because there is a B-line. So this is the typical pleural line COVID patients. Here another example. Here I've shown you, these are the two same images, but in the U-Light you can use another feature called needle vision. It's designed to if you want to insert a central line, for example, and you really want to see your needle, you can use this needle vision. It gives you a better idea of better vision on the needle, but also the thickened pleural line is also very nicely shown if you use this feature. This is personal, of course, but I like it. Here, excuse me, differences in COVID pathology. Here you see thickened pleural line. Maybe you could consider this normal. Debatable, but I would consider this a little bit thickened. Here, somewhat worse, you can see here consolidation. Here also a very tiny one with a B line. Here it is a bigger consolidation. Sorry. Bigger consolidation, again with the B line. Here, a much larger consolidation, and can become even larger in some patients. Here, interesting, you will see this pleural line, which is also irregular. It's not moving very much, but this is also a thing. If a patient has a really, it's really infectious at the level of this pleural line, the pleural fluid, although very little, can act as a kind of glue, which can inhibit the movement of the pleural line. Also in pneumonia, you can have this. So this exudate can act as a kind of glue, which inhibits the movement of the pleural line. Also, another thing is, if you use a lot of PEEP and low tidal volumes, also long sliding is diminished. But this was a patient who was turned in the prone position. And while scanning his back, you could see this really white, cloudy appearance below the pleural line, Merlin space, white curtain, let's say. And you could consider this white curtain as numerous B-lines together, which create this white curtain. Of course, when he's in the prone position for a couple of hours, this will more or less disappear. And what you will find then is probably something like this here on top of this image, because the fluid will descend to the lower parts. Also here, this is a posterior point image in a supine patient where you can see consolidations in and also a bigger consolidation with a little bit of pleural fluid in this patient. I just highlighted these things, these pathologic things, in this slide. We can see different kind of things in these COVID patients. Thickened pleural line, consolidations, bigger consolidations, some pleural fluid, and that's also an important thing. We don't see a lot of pleural fluid in COVID patients. That's really interesting. We keep them dry, that's true, but we don't see a lot of pleural fluid. If you see a huge amount of pleural fluid in a COVID patient, something else is going on also. You might consider surinfection or another cause of this pleural fluid production. But in COVID patients, you don't see a lot of pleural fluid. Again here, just to show you again, is irregular pleural line with these consolidations and some B lines here. So two little bit bigger consolidations, two consolidations between the two ribs. Okay. I have two cases. 2-3 weeks ago, I went to the emergency department because there was a patient, could be a COVID patient, 60-year-old woman, who was feeling dyspneic, head to cough, feeling very tired the last couple of days with low sats. The COVID test was performed, but didn't get the result yet, and the CT was planned. So I decided to use a lung ultrasound. And this was the pattern I saw. These four in the middle are the 4 blue points, upper blue points, lower blue points, and here posterior point where you can see here some consolidation, pleural fluid, and here at the anterior side, B lines, more than 2, between 2 ribs in every 4 of these regions. So this is pulmonary edema. This is not, these are not signs of COVID patients. This is a patient who was in pulmonary edema. Why? Because in kidneys, she was in kidney failure. But of course, afterwards, we could see the result of the chest X-ray, the CT, which also showed pulmonary edema, and the COVID test, luckily, was negative. Another case, also in the emergency department, same problem, dyspnea, cough, tired, low sats. COVID test, negative. CT was planned, and I used my lung ultrasound, and this is what I saw. At the upper blue points and the lower blue points, you can see here a thickened pleural line with small consolidations and B lines. Here, bigger consolidations, here, here, here. Here, irregular pleural line, thickened with also small consolidation present, B lines, and here 2 other consolidations. COVID test was negative, but the CT was positive for COVID. Ground glass consolidations, couldn't be more beautiful CT, considering this problem. But also lung ultrasound clearly show the presence of COVID pattern. Now, to conclude, I would say that a lung ultrasound in COVID patients can be very helpful. It can, like I showed you in these cases, it can differentiate pathology. It can differentiate between pulmonary edema. It can differentiate between a localized pneumonia, which I've also seen during the last weeks. Just very localized pneumonia, but all the other areas were normal. or specific COVID areas. What you will see most often is the C profile, which means irregular pleural line with consolidations, B lines. This is a typical thing you will see using lung ultrasound. Think about it, not a lot of pleural fluid, can be some, but not a huge amount. And also interesting, if you score the patients and you follow up the patients in the intensive care unit, you will see that when a patient is getting better, he will improve also at the anterior points first. So first of all, and I think the most important points are really the anterior chest points to look for. And also important, if your patient gets better, he will be extubated. These lungs are normal. And I don't know exactly how long it will take to recover fully of this COVID problem, but there are a lot of these signs are still present after the extubation of these patients. So I hope you can now resemble this image with COVID pattern used in lung ultrasound. And if there are any questions, I'll be happy or try to answer them. Thank you for your attention.
It was huge, a great presentation with lots of information. Thank you so much. And I think we will now address some questions of the people. Do you see those questions on the chat yourself?
I see a lot
yes, a lot of interaction.
A lot of interaction. I will try. There are a lot of I will see whether if I have a good
do you know the explanation of the thickness of pleural line in COVID patients? Do you know?
I think it's just inflammatory disease. I think inflammation of the lung pleural line and the consolidation below is just inflammation. I think.
And do you know how? Christopher Dovik also has an important question. How early in the clinical course will these changes appear? Can they be seen before saturation is affected?
Well, usually the patients I've seen is when they come into the emergency department, they have a lot of symptoms. So they have low sets, they have problems already, and then I do my lung ultrasound. Also the patients in the critical intensive care unit, they're already diagnosed with it. But the most interesting thing is that you can follow up the patient and look for improvement, look for worsening, and maybe, I don't know yet, we can use this scoring system to say, for example, the score is below, let's say, 20 or 18, it should be weanable. And then there is the problem of age, because what I've noticed is that the score can be much higher in younger patients. And the scoring is lower in older patients, but they are doing worse. So it's difficult. I think we will need to age adjust the scoring to see whether we can predict weaning or not. Or vice versa. Maybe we can predict this patient should be intubated or not. I don't know yet. I have to be honest. I don't know yet.
And there are some questions about how to be sure between pulmonary edema and COVID. And in the same kind of question, to differentiate cardiac and non-cardiac edema using lung ultrasound.
Yes. Well, the pulmonary edema is quite typical. You see a normal pleural line with more than 2 B lines between 2 ribs on each level. And it's quite synchronous, it's similar quite similar in these really, when there is really pulmonary edema, it's quite similar. There is quite some variability in COVID patients. but every region will be more or less affected. But you can see, for example, a quite normal one region that looks pretty normal, while the other regions have a lot of consolidations, look terrible. There is some variance, while in pulmonary edema you don't. That's the main difference. You also don't see irregular shaped pleural lines normally in pulmonary edema, unless, for example, the patient has been in pulmonary edema for quite some time and is getting sur-infected, etc., etc. But these are things out of the scope of this. But normally it should be quite easy to detect, like I've shown you in the cases. Pulmonary edema, normal pleural line with more than 2 B lines versus really regular shaped pleural lines with consolidations.
Yes, very clear. Thank you very much. There another important question from the field of Pr Bouchez. I guess he's from France. One question about COVID abnormal lung ultrasound. What is more frequent for you, unilateral or bilateral? Because most of the CT show bilateral abnormalities, but in his personal practice, he showed more unilateral abnormalities.
Yeah, you can have. I've seen several patients where you have, especially at one side, you can have homolungs. Say it's improving quite well, but that if you take into consideration the axillary points and the lower points, then often you will see these quite important consolidations still there. So COVID patients, you can have variability of pathologic regions versus maybe almost normal regions. You can have that, yes, exactly. But if you want, CT scan will allow you to, that's maybe a good question. The question I often get is, can we skip the CT scans in the emergency department? Now, in some hospitals, they do a CT scan in every patient. In our hospital, if you have an abnormal pathologic COVID chest X-ray, you don't get a CT scan. If you have a quite normal chest X-ray, you will get a CT scan. And then it's quite astonishing that you see a quite normal chest X-ray, and then if you see the CT, you can have a lot of consolidations, these ground glass consolidations. And I think lung ultrasound is another tool which is more sensitive, I think, but also again the deeper layers of the lungs, you can't use lung ultrasound for this. You always check, of course, the superficial parts of the lungs. And then you will see some discrepancy between CT and lung ultrasound. But in most cases, when the CT scan is quite positive, lung ultrasound will be as well. Yeah. Okay. Is the pleural line damage always present in COVID patients? Not always, but very frequently it is. If you consider, you can have one, maybe two regions, and then it looks a little bit normal, but that all the other regions are affected. And then you will see this irregular consolidation-like pattern, but you can have some regions. Also in ARDS, besides COVID patients, it is also the same pattern where you have this variability of regions where you can have more or less normal versus severely damage of the lung on lung ultrasound. This variability, this mixed pattern is also there. But the worse the patient is, the more consolidations, larger the consolidations, and the more regions the consolidations and the irregular pleural line is.
And what's interesting in this lung ultrasound for COVID patients is to follow it through the patient stage. I mean, outpatient and also intubated patients. And we have a lot of physicians this evening from Ukraine, and there are many questions about the scoring, and they want to know if you use the lung ultrasound score for ventilated patients.
Yes, that's what I try to do now in these COVID patients, because I was interested in the fact that if we can score these lungs, the severity, the pathology, whether we can use it to predict weaning, to predict intubation, to predict improvement or worsening of the patient. So I'm now trying to scan most of the patients and try to score this using these 5 points on each side of the patient to get a good idea of the severity of the lung. Yes, but of course it's a kind of research. There is no validated scoring system yet available in these for these patients. But even if not, if you use lung ultrasound, you can use a kind of scoring system by your own. Look for, what I do is a normal lung, A profile is considered 0. More than 2 B lines, I give 1 point. Irregular pleural line, I give 2 points. Ground class is 2 points. Irregular pleural line is 3 points. Small consolidations, 4 points. And then bigger consolidations, with or without pleural fluid, is 5 points. And so I check these 5, 3, 10 regions for the whole chest. And then I see what it looks like every day base and see whether the score increases or decreases. And it's quite interesting to see in this COVID patient that it looks like it can predict recovery of the patient. Yes.
And
but maybe.
Excuse me, Milton Valdez is asking if you have seen a correlation with Dr. Gattioni's L and H phenotypes in the COVID patients.
That's a good question, because I know there are publications on these different types, but to be honest, I didn't check the different types using lung ultrasound. I don't know if this is possible, because this is the problem of recruitment versus no recruitment, compliance, high compliance, etc. I don't know if functionality can be assessed in this way, these patients, because lung ultrasound is used more for structural. It's also a functional, if you consider lung sliding as a functional. But no, I didn't check these 2 types with lung ultrasound.
Yes. Okay, thank you. And another quick question from the south of France, from double lines and irregular pleural lines specific to COVID.
Double lines and irregular pleural lines specific to, yes. The irregular shape, thickened pleural line is a sign of disease. If you have, and that's why it's important to standardize your regions which you need to assess. If you see a consolidation present and the consolidation decreases and it goes into this irregular pleural line, this means the patient is improving. Otherwise, it's just a sign, a pathologic sign of COVID problems.
Yes, great. And maybe one last question. You must be very tired after all this information sharing. But from Italy, from Marco Valenti, what do you think of lung ultrasound in outpatients with a few symptoms?
Good question. Good question, because patients can have symptoms. They come to the hospital and then because they are not considered, they call it severe enough, they are sent back home. Maybe it would be interesting to check these patients whether they have already signs of severe COVID disease. Maybe, but I can't tell you the answer because I didn't check these patients. I only checked the patients who are really sick in the ER and in the intensive care unit.
Mm. Okay, well, I'm sure there are lots more questions that people would like to be addressed, but we have to.
But they can always send, if they really want my opinion, they can send me an email. I will try to answer them, or they can send it to you, and you can send it to me.
Sure. Of course, any question we may have, we will follow it to you and try to bring the answer to the physician around the world. So thank you very much, Professor Bouchez. We have a tradition in France nowadays. At 8 o'clock in the evening, we upload the physicians, and I'm sure the 600
in Belgium too. Yeah.
Along with us tonight are doing the same. So it was a great presentation. Thank you very much.
It's my pleasure.
And
Thank you.
For all of you who have some inquiries about ultrasound, ultra-portable system for lung ultrasound, we are here at your service. Do not hesitate to write us, to contact your local representative, and we will help you to get the right material to help you take care of the patient. When you will close this webinar, you will have there is a quick survey. If you have 2 minutes more to spare with us, it will be very interesting so we can improve the experience for the next webinars. And you can also recommend this session to other physicians so they will have a link to the replay of the tonight's event. So thank you very much, everybody. Thanks again, Professor Bouchez. Take care, everybody, wherever you are. We're going to win this fight against COVID, I'm sure. We have to. And we'll be very happy to see you again. Thank you very much.
Okay.
Thank you. Bye-bye. До свидания всем.